All right, I think we are live. So, welcome to the Women's Empowered August webinar event. We're excited to have everyone here, whether this is your first meeting with us or you've been here multiple times. But when we asked for different topics that we wanted to discuss to support one another, wellness was one that kept on coming around and around again. And I think if you are doing anything in 2026, you've heard of menopause and hormones as a hot topic. So we wanted to bring in experts on the topics to share and empower us today. So we're excited to have two guests here to speak with us. Dr. Simcox and Dr. Karp are joining us here today to present on women's wellness, perimenopause, and menopause and hormones. So the structure of our meeting today is they're going to share a presentation with their expertise. Please, as we're continuing, through the session, if questions pop up, add those into the chat. We are going to have a Q&A at the very end, but we're going to try and compile all those questions together. So just quick background on Dr. Karp and Dr. Simcox. Dr. Simcox is board certified or double board certified in obstetrics and gynecology and addiction medicine. So her practice is dedicated to care of women, pregnant women with substance abuse. And I'll let you guys give a little bit of overview as we start the presentation as well. She is employed by Carilion Clinic and works in general obstetrics and gynecology division there in Roanoke, Virginia. Dr. Karp is a board certified urogynecologist and associate professor in the Department of Obstetrics and Gynecology, also at Carilion in Roanoke, Virginia. She also specializes or completed a fellowship in female pelvic floor medicine and reconstructive surgery and at the University of Michigan. So I'll let you guys, as our experts, take it away. Thank you so much for joining and sharing with us today.
Okay. All right. Trying to get this to share. Can everybody hear me? All right.
I can hear you.
Good. Wonderful, wonderful. Okay. Let me get back to this. All right. Now I just got to get to the presenter view, right? We had this, guys. We really did. Okay. Can you see the main slide?
Looks good to me.
Awesome. Wonderful. Okay.
All right.
I'm Dr. Simcox, and I am a very good friend of Dr. Karp. The only person I would do a presentation with post call is for Dr. Karp. So I'll let you kind of start us off, Natalie.
Yeah, well, it's nice to virtually meet everybody, and we're really happy to have been invited. So we were invited to sort of just globally chat about women's wellness, hormones. We're going to chat a little bit about pelvic health because that's my specialty. And you can go ahead and advance, Kim, if you want.
Okay.
So just a quick reminder, we are doctors, but we're not your doctors. So this isn't medical advice at all. And you've heard a little bit about both of us and Dr. Simcox's specialty and my specialty. We both are very invested in improving women's quality of life, whether it's Dr. Simcox's practice, where she gets to help, really women of all ages and stages of life. But especially she has a focused practice in addiction medicine for women who are pregnant or postpartum with substance use disorders. She also delivered my second child, so she is a very, very trusted physician to me. I, am really invested in medical education. And then, both of us just sort of were jokingly, but not jokingly saying that we sort of our dislikes. So neither of us really likes to hear much about stigmas or sort of false narratives on things like mental health or hormone replacement therapy or UTIs and all those things. So hopefully we can dispel some of those myths for you all today.
Yes, ma'am. Okay. Well, I'm going to take over here. I have a feeling that just about every woman in this webinar has probably experienced or is going to experience the feeling of Oh my gosh, I have to shed all the layers of my clothes off and jump into the nearest refrigerator, right? I'm sure when you all are out showing houses, is in the realtor business and business meetings, hot flushes never come at convenient times. Now you can see the picture here of me and my family. We look super happy and comfortable, but actually I moved my son's bike helmet right in front of this giant sweat stain that happened. So we're all feeling different and different transitions of life. And I'm going to talk a little bit about what's normal, what's considered normal as we age, and what we can actually treat and what we really just don't have to put up with anymore, right? There's a lot of myths out there, but women now, we don't have to be miserable. We don't have to just brush it under the rug and consider changes of life normal. And, we have to be uncomfortable. The literature has really changed. The research has changed. So I'm excited to talk to y'all about that today. I wanted to start with a little like transition hormone over time primer here. We in our 30s, our ovaries are still operating regularly for most people. We have estrogen and progesterone levels that rise and fall in a really predictable monthly rhythm, like a metronome, right? You can see that pink squiggly line in the late reproductive phase, and it's nice and even and has a pattern. When we get into our 40s, which is where Dr. Karp and I are, we have realized that as the number of our eggs decline, which is a little bit sad, but I'm fine with that, we also have hormone levels that are starting to swing more widely and they're more unpredictable, right? So you can see a big higher than normal swing, sometimes a lower than normal swing within the same month, and that is perimenopause, everyone. It's these swings, not just low estrogen alone, that drive many of our perimenopausal symptoms. Periods also become irregular, maybe closer together, farther apart, lighter, heavier. There's really no rhyme or reason sometimes in perimenopause. When we enter menopause, that is it's a fixed time. The definition of menopause is when you have had no period for 12 months. There's really no exact hormone level that tells you, yes, you're on menopause. It really is the definition. I have not had a period in a full year. Once you have reached that stage, then you're considered to be in menopause. The average age is around 51. It can also commonly, occur for other women between like 45 and 56. So there is a range, but the average age is around 51. And in this stage, when you're postmenopausal, your estrogen level kind of settles. It's at a low, steady level for the rest of your life, right? And with these comes different symptoms. So we're going to talk a little bit about what are normal symptoms of perimenopause and menopause. So in perimenopause, which is again when we have these wide fluctuations in our hormones and our estrogen and progesterone, typically in our 40s, we can have irregular, unpredictable periods, heavier bleeding than normal, just, not as predictable patterns. We can also start getting some of those lovely hot flushes or hot flashes, is the colloquial term. And that can lead to, they can happen worse at night in some women. It can interrupt our sleep. We can also get a little bit more irritable, which my husband has loved. And then we also have brain fog. And I had a classic example of brain fog last night. I was doing a C-section, right? I've done a lot of C-sections. And I was trying to come up with a word for scissors, and I just couldn't come up with the word for scissors. So I just did this with my hands. And thank God the other ladies in there were going through something similar, and they were like, "We know what you're saying. It's scissors." So this brain fog, trouble with word finding, memory, concentration, some women also experience that. And then we also can have some change. It can be more difficult for us to lose weight, and it's typically around the midsection where it's harder to lose weight in the perimenopause and menopause time. I can look at a brownie and I look like I'm 38 weeks pregnant. So it's been a fun ride. Now, menopause is a little bit different. A lot of the same symptoms do continue into menopause, but we tend to have these lower estrogen levels. They're just lower, but they're more steady. You can still have hot flushes from low estrogen levels. You may have more genitourinary symptoms like vaginal dryness and irritation, and that's what Dr. Karp's going to be talking about. But then we may have more sleep disruption. Some women, it's easier to fall asleep. It's easier to they can go to sleep, but they can't stay asleep. And some women, it's the opposite. They can't fall asleep, so some insomnia can happen. We also have more rapid bone loss during menopause, and so that can really increase our fracture risk over time. So how do we manage this? So I hate this answer. This is my least favorite answer whenever I go to a doctor. You just need to exercise, right? And eat better, right? But it really does help in menopause and perimenopause. They actually say for more fat burning in perimenopause and menopause that strength training is more recommended. It also is a double benefit because you're gonna strength training, resistance training will help you with your muscle mass. They recommend a plant-forward diet, which is personally my like worst nightmare. But what they mean by that is something like a Mediterranean diet that's more plant forward. You can still have some fats and oils, but the plant-based diet is more like anti-inflammatory, which can really help some of your symptoms. They also say limit alcohol and caffeine. Yes, all the fun stuff. They recommend cooler sleep environment. So sleeping with a fan, sleeping on a chillo pillow, which is a cooling pillow, can help with these nighttime hot flushes. A cooling mattress. If you want to spend some money that's well spent money, the bed jet is really helpful for regulating your temperature at night and helping improve your sleep quality. Hot flushes can also be managed by both hormonal and non-hormonal options in perimenopause. Hormonal therapy is more effective because we're repleting the hormones that we have lost over time, but we do have some non-hormonal options and some of those are antidepressants and anti-anxiety medications that are called SSRIs or SNRIs. That can also cut down the frequency of hot flushes. We may have for our periods when they get erratic. I do say if your periods may be a little bit more unpredictable in onset, maybe a little heavier here and there. But if you're experiencing bleeding that's really heavy for like over 7 days at a time, if you're having more than one period in a month, that's when I say you really, sure, you can say it's perimenopause, but you probably want to see your gynecologist and get that evaluated because there are other causes of that. And you want to make sure you're not missing a endometrial or uterine precancerous or cancerous cells in your uterus. So make sure you're getting that evaluated. But as long as everything checks out and we don't think it's any sort of precancerous condition, hormonal methods are awesome to regulate your cycles. Mood and sleep, we can be improved by increasing the quality of your sleep, and then also cognitive behavioral therapy has been shown to be really helpful for some hot flush symptoms. Cognitive behavioral therapy or CBT doesn't alter your hormones, but it does change how women cope with any of these symptoms. It uses cognitive restructuring, paced breathing, psychoeducation, and that can kind of help the distress that's caused by some of these symptoms. So while it sounds like, how does therapy work? It works. And there have been a lot of randomized controlled trials to show benefit. Hot menopause, that's where you have the lowest estrogen levels. So really the best thing for hot flushes is going to be hormone therapy. That really can reduce hot flushes by about 75%, but you can still also consider non-hormonal and prescriptions. And there's a new neurokinin blocker medication that showed some great efficacy. Dr. Karp is going to cover some of the vaginal and urinary symptoms of menopause. We also have to think about our bones as we enter menopause, right? We are losing, without estrogen, we're losing some of our bone mineral density. So making sure you're increasing your resistance exercises, taking vitamin and calcium supplements, avoiding smoking that can lead to bone loss. And you can consider hormone therapy if you're having hot flush or other vasomotor symptoms, but there are also some bone specific drugs that you can take. So why does it matter from your quality of life? Well, I think it's pretty obvious, right? Brain fog and fatigue that can affect our our careers, right? It's men don't have to go through this. We have to. And it can be really distracting and distressing for us when we can't, our train of thought isn't we want it to be. We can also have more hormonal swings that can affect our job. But really, it's the long term that we need to also focus on. The number one killer of women is heart disease. So when we lose our hormones and our estrogen, we are automatic increased risk for cardiovascular disease later in life. So this is the time we really need to buckle down and concentrate on improving our bone mass, right? And increasing and improving our heart health. So we'll talk a little bit about that in just a second. So, when to talk to your provider, when you are having disruptive hot flushes, when you're starting to experience these significant mood changes, this isn't something you just have to tough out, brush under the rug. Of course, if you're having any strange bleeding patterns, like we talked about, bleeding, very erratically over 7 days a month, having more than one period a month, I definitely think you should contact your gynecologist. The other thing is if you have any bleeding after a year of not having any bleeding, that needs to be evaluated pretty promptly. In our practice, we really prioritize anybody that calls with postmenopausal bleeding so that we could potentially catch something precancerous or cancerous going on and treat it. So we don't have to tough it out. Gone are those days. And this is largely because there was a study, and a lot of y'all have probably heard of it. It was the Women's Health Initiative study. It was performed about like 20 years ago. Unfortunately, that study was widely misinterpreted. And what resulted from that was a lot of fear mongering. Basically, doctors were told, take everybody off hormones. These hormones are going to cause cancer. And it really, really scared people. And then women just kind of had to deal with it, deal with their menopausal symptoms, right? They were afraid of hormones, but careful reanalysis of those study results. And there's a really cool, I have a little thing in the slide that kind of tells all the progression of the studies and what happened each year and when things changed. But what they found is that it's really that hormones are safe. You just there's some nuance to the type of hormone you might use, the dose that's most effective for you, the route you take, and the timing in which you start hormonal therapy in relation to when you started menopause. So it's definitely something to discuss, but there are options. There's hope for us, thank goodness. So who are good hormone? HRT is hormone replacement therapy. Who are good hormone candidates? In general, those women typically under 60, and this is initiating hormone therapy, women under 60 or within 10 years of the last period. If we start hormonal therapy, meaning estrogen estrogen, progesterone, within this time range, then it actually can be considered cardioprotective and protect our heart health, which is great. We also, if you have a lot of bothersome hot flushes and night sweats, you don't need to live like that, right? Probably be a great candidate for HRT. The patch gel, there's patches, there's gel estrogen forms of estrogen that can be a lower clot risk to you than pills. And then if you do have a uterus, your provider may talk to you about the need to protect your uterine lining with progesterone hormone, because estrogen can stimulate the lining of the uterus to grow, and that could put you at slightly increased risk for developing precancerous cells as cells multiply. So we give you a progesterone to help reduce that chance. So you get your estrogen, but you're also protecting your uterus. All right. So people that may want to avoid, like hormonal therapy, meaning estrogen and progesterone. If you have a breast or hormone sensitive cancer, you may not be as good of a candidate. If you have active blood clots, stroke, or pretty progressed heart disease, you want to talk to your physician. Active liver disease could be a contraindication. If of course we don't know why you're having this abnormal bleeding, always get evaluated first so we can rule out other causes that could be more more concerning and more dangerous. If you start hormonal therapy over 10 years after menopause or after the age of 60, there are some increased risks of potentially worsening your cardiovascular health. So you're really going to need to have a good informed conversation with your healthcare providers. And this is oral. But interestingly, low dose vaginal estrogen is safe for most people, even if you have some of the conditions that we talked about. So, vaginal dryness and discomfort with intercourse could be managed in just about every patient safely. So, Dr. Karp will talk about that. There's lots of myths out there that we're going to bust really quick before I turn it over to Natalie. The Women's Health Initiative study, they kind of scared everybody. Everybody thought that they were going to get breast cancer if there are any hormonal therapy. That risk is actually really small. It depends on the type and the duration of the therapy, and and estrogen alone therapy does not have that increased risk of cancer, right? So, little to no increase in breast cancer risk with estrogen therapy alone. Another myth is hormones prevent heart disease, so everyone should take them. Well, the reality is that hormone therapy is not prescribed just to prevent heart disease or progress bone mineral density loss, bone loss. Sorry, that didn't make any sense. So the reality is that you can start it while you can start it to treat symptoms. We don't put you on hormone therapy just to be protective later in life. So that's we may get to that point one day, but our research doesn't support starting it just for prevention at this time. But stay tuned, that may change. So there's also a myth that you must stop at a fixed age or after 5 years. I don't know where that 5 year number came out of the sky, but a lot of patients say, okay, well, I'll start it and I'll just stop at 5 years, right? There's really no stop date. As long as you are getting benefit from hormonal therapy and it outweighs the risk, and you have periodic check-ins with your gynecologist, you can continue that hormonal therapy if it's making you feel like yourself again, right? There's also a lot of controversy around bioidentical hormones, right? We get this question all the time. Oh, yes. And we'll talk about the social media impact of that. In reality, we are hormones that we are giving you and prescribing you as doctors are FDA approved bioidentical hormones. It's the same thing. It has known doses and quantities. A lot of these custom compounded products that they're selling on the media and at a lot of these popped up med spa places, they may not be FDA regulated and are not proven to be safer. They can also have unpredictable dosing. So we are seeing an uptick in endometrial cancers from people that are taking a lot of these exogenous hormones that they're buying like online or from people that aren't trained to provide FDA approved medications. So I think there's a lot of controversy, and I think bioidentical hormones are that word term is thrown around, but what we do prescribe is considered bioidentical. It's just and you want to be cautious with these claims online. They're selling everything, these menopause bundle supplements, but they found that black cohosh, the phytoestrogen supplements, and most menopause supplements have really not been shown to work better than placebo for hot flushes. And the herbs and supplements, really, they can't be recommended at this time for as effective treatments, just with the data that we have. But what we can recommend is calcium and vitamin D to support your bone health as we enter menopause. And if, really the rule of thumb, if something sounds like a miracle cure, discuss it with your provider before you're spending a bunch of money. Okay. A lot of people that get the hormone testing and spend a bunch of out-of-pocket money for hormones, it's really not accurate, and you can actually be put at risk by starting some of these the pellet therapy and the things that have a lot of unregulated modes of delivery to your body. And we really want to be careful with that. So please talk to your provider before you're considering any of those options. Because we recommend FDA approved hormone options that are just as bioidentical, but tested and also reversible. So, Great information there. All right. So, well, women screening, while you're talking to your provider about the transition in your life, about some of the symptoms that you're feeling, remember you can check in with your gynecologist or primary care provider about your regular health screening. So don't forget to, get an occasional blood pressure, cholesterol, diabetes screen, right? And some gynecologists will do this, some primary care, most primary cares should be doing this. We also recommend mammograms that begin at 40 and are every 1 to 2 years. We recommend cervical screening or your pap smears, everybody's favorite, every 3 to 5 years, and they may stop around 65 if you don't have any, if you have all prior normal screening. So that's one happy thing about turning 65. Colon cancer, remember to start your colonoscopy or your approved like Hemoccult testing around 45 years old. And so talk to your primary care, your gynecologist about that. There's some people that would qualify for lung CTs if they have significant smoking history. Bone mineral density typically starts at 65 or earlier if you have risk factors. And it's also good to touch base with a provider about your mood, right? Mood check-in, sexually transmitted infection risks, alcohol and tobacco counseling, and any vaccines that you may be behind on. So I'm going to turn it over to Natalie to talk about the really fun stuff. All right. Natalie, you want me to stop sharing?
Yeah, that would be great.
All right.
All right, everyone. Let's see. Hopefully,
We
this is
got this.
working. All right. Does that look okay to you, Kim?
I can see it.
All right. All right. Well, we're going to keep on rolling from there. And I see all the questions popping up in the chat, so we're excited to get to those. So we're going to chat a little bit about some pelvic health symptoms, which I think are also really common, especially in sort of this, 30s and upward stage of life. And we like to say common, but not normal. So when we think about, first of all, like who am I and what is my job even? So a urogynecologist is a specialist and you do have, they're sort of all over the country. So for those of you who are in Greenville, you do have fellowship trained urogynecologists. They've done 4 years of an OBGYN residency and then 3 additional years in subspecialty training. And we treat pelvic floor disorders, which means bladder and bowel incontinence, pelvic organ prolapse, urinary tract infections, bladder pain, things like that. So that's what I do. And we also think a lot about the pelvic floor. So what is the pelvic floor? The pelvic floor is basically the sling of muscles and connective tissues that supports your bladder and your vagina and rectum. And it functions in sort of overall core stability, in support of your vaginal walls and your uterus, and also in continence, which is keeping control over both your bladder and your bowels. And so, for those folks who have ever been pregnant or delivered children, especially vaginally, you might have some changes in your pelvic floor. One thing that we think about is different changes in urinary symptoms. And so, one of the things, and it should have been an animation, but it didn't, sorry about that. But there's stress urinary incontinence. So, what is stress urinary incontinence? First of all, about almost 40% of women overall report some sort of bothersome change in urinary symptoms that interferes with their everyday life. So, especially if you are a busy working woman, these things can really interfere if you're driving around, running around to things, trying to get your exercise in. So stress incontinence is leakage of urine with any sort of impact, anything that increases the pressure in your abdomen or your belly. So running, jumping, coughing. I feel like we should have advertisements in trampoline parks where our kids, are going and, moms or family members are there. This can impact, how often you want to exercise, your sexual function, and we treat this in a range of ways. There's behavioral changes you can make. There's dedicated pelvic floor physical therapy. There's things that you can wear in the vagina, and then we also have surgeries that we can do. Let me see if this will. Nope, probably won't. All right. So then we also have overactive bladder. So overactive bladder is basically when we have increased urgency to urinate. So a lot of times people will say, whenever I go somewhere, I have to know where the bathroom is immediately. And then you might have leakage before you even get to the bathroom. So oftentimes this is triggered by like your routine or your habits. You might notice that every time you get home, if you were driving 45 minutes or an hour to show a house or to go to an important meeting, as soon as you get home, you put that key in the door, you sort of feel this sudden urge, your hydration. And then what are you drinking? Are you drinking a lot of sodas, coffees, teas, things like that? Both types of sweeteners, regular sugar and artificial, can be irritating to the bladder and sort of worsen that urgency. And we have different treatments. We can do medications. We have, nerve stimulator treatments. We have Botox that we can actually inject in your bladder. So it's not just for wrinkles. But we have a lot of different options to help you manage these symptoms so that you can have improved quality of life. And then a lot of people sort of wonder, what is prolapse? So just for a quick orientation, this is showing sort of a cross view. If we were sort of looking at a woman from front to back and cut down the middle, this is a woman who's had a prior hysterectomy. And so when we think about, what even is prolapse, it's a change in support. So this is the bladder. And this is the vagina, and then these are the bowels back here. And then there's pelvic floor muscles that sort of hold everything in place. So when people complain of prolapse, they're talking about a change in support of the vaginal walls, and the vaginal wall drops down, and sometimes those walls are supporting other structures like your bladder, and so they kind of drop down along with it. Um, Risk factors are things like increasing age and menopause, unfortunately, pregnancy and childbirth. And then, certain chronic health conditions, if you have a chronic cough or chronic constipation, if you are a power lifter, if your weight can impact it and those sorts of things. And we do have different treatments. There's pelvic floor physical therapy. There's things that you can wear in the vagina to hold up. Some people will wear all the time. Some people will just wear, with their exercise regimen or when they need to. And then there's different surgeries that we can do as well. All right. So something that comes up a lot in our patient population, especially in the sort of perimenopausal and postmenopausal age ranges, are urinary tract infections or UTIs. So probably a lot of women, might have experienced at least one UTI in their lifetime. And we know the classic symptoms of burning with urination, sort of increased urgency, bladder pain. You might have blood in your urine. If it's a bad infection, you might have a fever. But what we've learned over time through great research is that menopause and the change in the hormones increases your susceptibility to UTIs. And that's why we'll get to this a little bit more. That's why we treat sort of repeated UTIs in after menopause by adding back some vaginal estrogen. But it's important to note that if you are having a lot of UTIs and symptoms, you do need testing. So you do need to have sort of that check-in of making sure that you have a culture to check and see what bacteria is growing in your urine. And then when we think about prevention, we can give women, antibiotics after sex. So that's the postcoital antibiotics that you'll just take once after sex. If you notice that it seems to be triggered by sex, we can give you vaginal estrogen, which I talked about. Sometimes we'll put you on low dose antibiotics or some other supplements or medications that you can take. What Kim was talking about earlier that we promised we would get to is something called genitourinary syndrome of menopause, which is kind of a mouthful. But we're basically talking about the changes that happen to all of the skin and tissues and just sort of a quick, anatomy. I know you all might not always be used to seeing these pictures, but we as gynecologists are. And so there's tissue changes that happen not only in the vagina, but also in, what we call your vulva or your labia. that can cause discomfort, like vaginal and dryness, sensitivity of the tissues, painful sex, and it also contributes to some of the bladder symptoms and the UTIs. And it's not just when you're in menopause, because there's other things in life that can affect your hormones. So, for example, if you're exclusively breastfeeding, that's actually suppressing some of your estrogen. That's why you don't always get a regular period. But women can have these same symptoms, and the treatment's the same. So we have low dose vaginal estrogen. It comes in creams, it comes in vaginal suppositories, it comes in rings, and it's really safe for pretty much almost everyone, even in women with a history of breast cancer, can still typically use a low dose of vaginal estrogen. And it's really great at treating all of these things. And it's the best thing we have for preventing UTIs in women who are, typically postmenopausal or menopausal. But I also have seen the changes in women who are perimenopausal as well. And I think that sort of wraps up our portion. One thing I want to remind you is, that we really do try to say, and I just want to reiterate Dr. Simcox's point that common doesn't equal normal. So all of these things are common and, really widely experienced by women, but it doesn't necessarily, we don't want to call them normal per se. We don't want to say you just have to tough it out. You don't have to. You may choose not to treat any of these things. You might not be bothered by your urinary symptoms. You might have a little bit of prolapse that you're not bothered by. You may not be bothered by some of the perimenopausal and menopausal symptoms. But if they do bother you, there's a lot of resources for help. And we have a couple of links here for sort of patient forward education to help you sort that out. So I'm going to go ahead and stop sharing now. Oh, and then Kim added this picture because another thing that can help us all is to have some good boundaries so that we can take good care of ourselves and not just always put ourselves last.
Oh, yes.
Oh, yes.
Favorite pillow. And Natalie, I'm joining from my phone just since I got to get on the
Perfect.
road. But yeah, but I still can hear everything. Just read out any
We
questions for
can
me.
hear you.
Perfect. And for those of you that can't see the chat, I just wanted to add that there's some really great resources, and my favorite website to go to for any sort of like basic menopausal education for patients and for providers is a website called the American Menopause Society. It was previously known as the North American Menopause Society, but I guess they were going to be more inclusive, not forget the South, so they made it the American Menopause Society. So it is a great, great website. They are responsible for all of the evidence-based medicine regarding menopausal management. It has got just a plethora of cool tips and tricks that women can use for menopausal management of their symptoms. And another awesome documentary film that came out, and it had a bunch of celebrities talking about menopause too, it's called the M Factor, or the M Factor, and it's all about the Women's Health Initiative study and when everybody got scared of using hormones and the damage it really did long term to women, and just having to tough it out without any options. So really cool documentary there if you're interested.
Thanks so much, Kim. There is, so I think one of the questions, I see two questions in the Q&A. One's been answered about, the how long can you do hormone replacement, and Dr. Simcox answered that there's really no set timeline for that. And then Kim, there's another question for you. What are the options for women outside of the 10 years of last period? Sort of doing all of our things, and what should they be doing to sort of stay ahead of the game? And I'll just add that, in addition to sort of the routine screening, like staying on top of your breast screening, pap smears if you still meet criteria for that, colon screening especially. I think it probably, and I'll let Dr. Simcox add too, really sort of depends on what symptoms you're having, because the goal again is not necessarily the goal. We know that hormone replacement can help prevent things like bone density loss, and there's screenings and things you need to follow for your heart health and for that. But the goal of the treatment is for your symptoms. Do you have anything to add? And the same thing, I'll add my little pelvic health plug. Don't forget, like we have your gynecologist, we have pelvic floor physical therapists. So if you're having symptoms along those lines, don't hesitate to see someone. Do you have anything to add, Kim?
I would just say that, I think everybody has different risk factors. Everybody has different basic, health concerns. There are some patients, if you're really well counseled, and we think that even though you're outside of the 10 years, that you'd still be a pretty safe person to try a little low dose estrogen on. I mean, I think that I don't think that just because you're over the 10 years, it's a no-go. We also have like non-hormonal options if there is a risk to help with menopausal symptoms. We have you can still use vaginal estrogen. So you don't, even if you're outside of that like preferred range, and that's more because of the cardiovascular risk. If you started outside of 10 years of onset of menopause, then it could potentially cause more plaque formation in the arteries. So it's really just coming down to your risk. Do you have prior risk for heart disease? And then you kind of go from there with your provider on what risk on the risk and benefits of hormonal therapy. So nothing. I mean, everybody's an individual. Meet and talk, but the bottom line is you have options. We don't have to suffer. And then does that answer that, Natalie? I had another thought. I forgot what it was because
No,
I'm
that was
in
perfect.
perimenopause.
There's another quick question about, does continuing birth control pills have benefits during perimenopause?
Oh, yeah. I love a good birth control because what you're getting is estradiol and progesterone. So, a birth control pill can be super effective, super easy. A lot of women that also need the actual birth control because they are still of reproductive age, they have not hit menopause yet. A birth control is a great way to knock out two birds with one stone, no babies and no and reduction in hot flush and brain fog and concentration. So yes, you birth control pills can be a great option for a lot of women. As we age a little bit, then sometimes we might want to consider switching to like an estrogen patch with a little bit slightly lower risk of blood clots because some birth controls could potentially increase your risk for blood clots. And I think somebody asked a question about the patch. The patch is just a little lower risk for blood clots, so that may be sometimes our first line to go to. It's also super, just really wildly effective. So lots of options there.
And then Kim, have you had there's a question in the chat sort of about the nationwide shortage on the patches, which of course we've heard a lot about.
Oh
Um,
yeah.
what
Oh yeah.
have you, and I will say locally it seems like our patients a lot of them have still been able to get patches, but have you had any the sort of formulary switches or successes in obtaining those for patients?
Yeah, that's a great question. I think it depends on. I just think it depends on where you are, what pharmacy you have available. What we tend to do is a lot of the, like the nationwide, like send-in pharmacies, like that. Sometimes we'll get some luck with, some of those pharmacies. We also, if we really are struggling getting something, we might temporarily switch to an oral formation. We may temporarily switch to like compounding, like gel
Mhm.
estrogen gel in some cases. I have not had a ton of issues. I'm usually able to switch to something that's covered by insurance. I have a pocket pharmacist friend though, so if I run into a problem, I just tell him, "Hey, go hunt this one out. Tell me where I can get it." So,
Yeah, so
like
that might be a
express
good
scripts, yeah.
Yeah, and that's a great question. Sometimes, you can even ask, like pharmacists are wonderful. And so you can even ask the pharmacist if they've, sort of heard from their colleagues, if there's folks that have it in stock. Or, you can sort of ask your doctor about like a temporary formulary switch, and then you can check. I know some of the national ones, but there's Amazon Pharmacy, and then there's also thinking about brain fog. I'm blanking on the name of the other national one that we use a lot for vaginal estrogen, but there's some good national sort of options that will ship and send. And then there's through your insurance, there's usually a online pharmacy option as well for sort of bulk orders. So they might be able to tell you when they're going to get it back in stock. It looks like Audrey's updated the links, and oh, I'm sorry. It sounds like a lot of things are out in Vermont. I'm sorry, Sarah. That's really tough. I think we've gotten through most of the questions that I have been able to see and find um, in the chat and in the Q&A. I guess we've just been sort of lucky in our region of Virginia where we still have a lot of pharmacies that have things in stock. But
Yeah. And
I will
one
say,
thing.
that's a great question for, and it might just be that everyone's out sort of regionally, but that's a great question. Your local providers might sort of be encountering this through their, local networks and hearing from colleagues, and they might have some advice.
Right. And another thing is when you call the pharmacy, you can say, "Hey, well, what can you cover? Where do you think I can get this?" And we can get around it. And it's just, it's just infuriating because I'm sure there's no shortage of Viagra anywhere, right? So sorry, I have to make a snarky comment, but it just goes to show that, women's health really needs to be prioritized. And so, anytime you can advocate for that, for improved women's health access, I mean, raise your voice because I think women all over the world, we've been kind of brushed under, kind of dismissed with our concerns, and especially when it comes to women's research. So advocate, and then, make a pharmacist your best friend is one of my biggest pieces of advice.
And then when we think about, just sort of making a plug for vaginal estrogen, sometimes insurance companies don't always cover the vaginal formulation. But for those of you who have ever encountered GoodRx and GoodRx coupons, there's some really good coupons for all sorts of different medications. But for example, vaginal estrogen, if not covered, can be like hundreds of dollars per tube, whereas like on a GoodRx coupon is like $30 to $40. And a tube will last most women about 3 to 4 months. So we have some really good options. I think that there's a question in the chat about, vitamin D supplements and calcium supplements, which I think Dr. Simcox answered earlier in the chat. And she said she would continue a daily supplement. And so that's still recommended for most patients.
And a secondary benefit of vitamin D too is it can really help your immune system. So that's another thing. Just continue to take a daily supplement. I've really never seen. I don't think I've ever seen personally anybody with too high a vitamin D level. So I mean, it can happen, yes, but most of the times people are more like low normal or normal, especially those that live in less sunlight.
Right. And again, you might get differing advice from your own physicians if you have different conditions like kidney stones and things like that. So this is all not intended to be individual advice. This is all sort of global standard, evidence-based recommendations. But for individual questions about your personal treatments, those are best directed towards your own doctors who have your whole health history on file.
Thank you, Dr. Karp and Dr. Simcox. This was really helpful, and everything from kind of the small tips and tricks about trying to track down prescriptions to kind of the bigger educational message. And I wrote down common is not normal, and I think that's something in this day and age. We mentioned everyone's talking about menopause, perimenopause, and these symptoms. I have many a friend who pees in a trampoline park or on a run, and I really liked your advice that common doesn't necessarily mean normal, and more education helps us to advocate and then go back to our personal providers. So thank you so much for taking the time and chatting with us today. It was really informative to me, and I know helpful to our group.
All right. Thank you all again so much for the invitation, and we hope you all enjoyed it. And, thanks for letting us chat with you about women's health.
Thank y'all.
All
I'm
right.
going
Thanks,
to share my
everyone.
I'm going to share my screen and just run down upcoming events that we have. We do have a September meeting scheduled, and then GNE obviously coming up in October. So September, our topic is rewriting the narrative, moving beyond self-doubt into confidence. So excited to talk a little bit more about mindset in life and in business. But October, obviously, big upcoming events for GNE in San Francisco. So I'm sure many of you, if you're on this call, you've received emails about the events and opportunities to sign up. So you'll be, continuing to get those. I think the Maritime Food Tour is limited in terms of space, so make sure to RSVP for that. And we'll be sending out more information about both coffee walks and then Ladies Who Lunch location. Those are really, kind of low stress ways to connect with others at GNE and to, kind of help fill out your calendar and meet other folks. So I hope you'll consider, volunteering to lead one of those events and certainly join. But we're excited to meet and connect with everyone together in person. So thanks so much for joining us today. I hope that you found this talk helpful, kind of a different, area of wellness for us to cover together. All right. Thanks y'all so much.